Hi, everyone. Thank you so much for joining. We will give it just a couple minutes for some more people to join, and then we will get started. Thank you for being here today. Good morning and good afternoon again to everyone who is just joining us. We'll give just one more minute and then we'll go ahead and get started with the webinar. All right, so it is 3 minutes before the hour, so we can go ahead, or after the hour, so we can go ahead and begin. So hello, everybody, and welcome to today's webinar, which is hosted by the Coalition Against Hepatitis for People of African Origin, which is also known as CHIPO, at the Hepatitis B Foundation. My name is Beatrice Zovich, and I'm a Public Health Program Manager at the Hep B Foundation and the main administrator of CHIPO. Thank you so much for tuning in today. Today's webinar is focused on the African Caribbean Cancer Consortium, which is specifically centered on current efforts and initiatives to address the disproportionate burden of hepatocellular carcinoma, or primary liver cancer, in African and Caribbean communities globally. We'll have an opportunity today to hear from an esteemed speaker who has done some considerable work in this area as part of the consortium, and who will be able to share with us some background information about the group as a whole, as well as valuable perspectives that can hopefully have broad application. So we look forward to this really important presentation. Next slide, please. So before we get started, I would just like to remind all participants that during today's webinar, all audience members are muted. So we encourage you to use the chat feature to let us know who you are and where you are joining from. And if you have any technical challenges, please indicate your issue using the chat box and we will address it as soon as possible. And then if at any time during the presentation you have questions, you can feel free to enter them into the Q&A box, and questions will be addressed by our speaker at the conclusion of the discussion. This session is also being recorded, and the recording and slides will be shared with attendees following the webinar. Next slide, please.
Yeah. It won't let me advance. It's just showing that it's buffering. So
okay, no problem. So I'll just give a quick kind of verbal overview of what CHIPO is and the Coalition Against Hepatitis for People of African Origin. So this is a community coalition that was co-founded and led by the Hepatitis B Foundation. And we're composed of organizations and individuals who are interested in addressing the high rates of hepatitis B infection among African communities, both in the United States diaspora and around the world, particularly in Africa itself. So CHIPO serves as a forum for sharing information and best practices and improving capacity to increase hepatitis B awareness, testing, vaccination, and linkage to care among highly impacted African communities. We currently have over 60 coalition members from across the United States and around Africa. So today we are very excited and honored to be joined by Dr. Patricia Jones, who is a hepatologist and associate professor of clinical medicine at the University of Miami Miller School of Medicine in the Division of Digestive Health and Liver Diseases. Dr. Jones takes a multi-pronged approach to researching disparities in hepatocellular carcinoma and chronic liver disease. She leads the Liver Cancer Tumor Board, and she also participates in multiple studies that are funded by the National Institutes for Health in the United States, which investigate the multi-level determinants that contribute to disparities in outcomes and barriers for primary liver cancer screening. Dr. Jones is a member of various associations, including the American Gastroenterological Association and the American Association for Cancer Research and for the Study of Liver Disease. And she serves on the research committee of the American College of Gastroenterology, where she chairs the Health Equity Research Award Committee. She's also a co-leader of the African Caribbean Cancer Consortium Liver Cancer Working Group, which is what today's talk will focus on. We're very excited to hear from Dr. Jones today, and we're grateful for joining us. So without further ado, I will invite Dr. Jones to get us started. And just a reminder to audience members that you're welcome to put any questions you may have in the Q&A box throughout the presentation, and all questions will be addressed at the conclusion. So thank you so much. Quinn, you can feel free to stop sharing. Thank you.
Have to unmute before I can share, or I can't see it. So give me 1 second.
Take your time. Thank you.
Okay, so you can
Perfect.
see my screen, no problems?
Perfect.
Okay, perfect. All right. So thank you very much for the invitation. I really have enjoyed working with the Hepatitis B Foundation and CHIPO, and I'm delighted to speak today about the African Caribbean Cancer Consortium. We're going to start by just giving a background of the consortium and how it works, and then we'll talk specifically about the Liver Cancer Working Group. All right, so let me just move that a little bit out of my way. Okay, perfect. So AC3 is the African Caribbean Cancer Consortium. It was actually founded in 2006. And in 2007, there were two goals. One was to provide a forum for the formalization and coordination of collaborations between the investigators from the United States, Caribbean, and Africa. And then AC3 meetings would serve as a medium for these investigators to present their data, also to formally discuss the coordination of future collaborations and to seek funding to support case control studies of cancer risk across these populations. So if you build it, it will come. This just shows sort of how AC3 has grown and all of the different states, countries, regions where we have representative. We have members in the United States from 18 states, 10 countries represented in Africa, and 17 countries represented in the Caribbean. And the purpose is to conduct and coordinate team science, to build resources and capacity. Really important is building skills, promoting advancement of careers. And so you can see all of the different areas that we focus on: behavioral science, community health science, cancer registration, genetics, genomics, advocacy, molecular cell biology, and so on and so forth. And this has been an initiative funded by the National Cancer Institute, which has been really important for funding the conferences where we meet and collaborate. So in terms of the leadership structure, there's regional leaders. We have 3 leaders, one to represent the United States, and that's Dr. Camille Reagan at Fox Chase Cancer Center, and she's actually the founder of the consortium. Others include Dr. Greaves, who is in the Caribbean. She's at University of the West Indies in Cave Hill in Barbados. And then in Sub-Saharan Africa, we have Dr. Gatheri at the Kenya Medical Research Institute, also known as KEMRI, in Nairobi, Kenya. We also have governance and accountability. And so we have the Research Ethics and Review Committee, and these names are all represented. And you can see that there's always an effort to make sure that there's representation from the United States, the Caribbean, and also Africa, so that everything that we do is sort of representative of all of these stakeholders. So we have different working groups. We have a colorectal working group, and here you have represented the 3 leads. And again, with each working group, there's a leader from the United States, a leader from the Caribbean, and a leader from Africa. And so we have colorectal cancer, head and neck cancer. We have a newly inaugurated pathology working group, a prostate cancer working group, a women's cancer working group. And you can see that there's a lot of leaders for that group because there are also many types of women's cancer, such as breast cancer, ovarian cancer, endometrial cancer, et cetera. And so that's a much larger group. And then the liver group, I'm the US co-lead, and I'm joined by colleagues, Dr. Kabaya and Banidine, who are from Kenya and Martinique, respectively. So this is just some photos from the conferences. This is actually the most recent conference we had in October of 2023. It was held in Mombasa, Kenya. It was a wonderful conference. Oh, look, those are photos of me. So that's a photo. We had a really wonderful reception. And then other just really great opportunities to work with each other collegially and to work about science. And it's all levels from medical students all the way up to full professors. The idea is that there's transparency, supportiveness, fairness, and trust. We know there's a history of mistrust when it comes to research for lots of very good reasons. And it's really important that as we're thinking about science, we're really thinking about the relationship between investigators and not even so much the scientific question, because if there's no relationship, then the question doesn't matter. So the important components of advocacy, we work in the community. We went to a church, for example, and talked about prostate cancer and breast cancer. Humility, commitment, and teamwork is the secret to our success. So we're very different in terms of other consortiums with regards to infrastructure, expertise, resources, but mainly the idea that we are all in different places. And so when we're thinking about projects that we have to do, we have to think of projects that is something that can be done in all the sites, right? So that all of our stakeholders, is not just a project that we can do in the United States or that can be done in the Caribbean, but can't be done in the other regions. And I'll talk a little bit about that when I talk about specific projects. One second, I'm just going to minimize that. So, okay. So in the same way that the U.S. leads the efforts in the U.S., it's really important that African and Caribbean investigators lead efforts in their respective regions. So a lot of this is sort of capacity building and infrastructure building rather than sort of like parachuting in and saying, well, this is the way it works where I am, and so let's do it that way. But really like learning, best practices and what our co-investigators want to do, and then supporting it in that way. So this is just a timeline. Again, the idea was conceived in 2006, and this is a timeline of the various conferences. The very first international scientific meeting was held in Jamaica and the West Indies, and the 8th international scientific training meeting I just mentioned was in Mombasa, Kenya. And sort of just the ideas, sharing research accomplishments and building new collaborations, building capacity, advancing cancer health equity, defining and achieving milestones in cancer care collaboration and research. The most recent conference was Community and Molecular Approaches in Early Screening and Diagnosis to Promote Equitable Outcomes through the Continuum of Care in Cancer among populations of African ancestry. And again, there's some support from the NIH, but there's some support from others as well, other sponsors as well, including some of the institutions that we all come from, help to support the meeting. So just some other photos, again, of our most recent meeting, and you see a lot of engagement with the audience. This was sort of a single room that we had our conference in. And there's professional development, networking, and roundtable sessions as well. So it's really an opportunity for the more junior among us to think about things. We talked about teen science, sharing responsibilities, how to conduct literature reviews, building an effective mentorship team, how to balance academia and clinical practice. This is something that I think we all struggle with, leveraging machine learning and AI for research, and then thinking about career development, whether or not people are interested in going towards academia versus industry, for example. So the training topics, again, 2019, we had a training session, and it was Community Research Navigator Master Trainer Workshop, Molecular Pathology Training Workshop, and then Research Readiness Workshop. And in 2023, we talked about Implementation Science 101. Effective scientific writing and publishing, grant writing refresher, and the nuts and bolts of grant management and reporting. So this was actually a one-day conference before the scientific session started. And the idea is that people throughout the world don't necessarily have access to all of this didactic training on how to write a paper that is going to get published, how to write a grant, and what are the nuts and bolts once you get that grant in terms of reporting. And so this was like something that was important for really all of our mentees and our junior faculty. And even those of us that are more senior learned a lot as well. We had a mentor-mentee matching program. There was an NCI granted P20, and African and Caribbean investigators were matched with U.S. mentors to help them to further develop their research program, and then a grant writing immersion program also funded by the NCI. So now I'm going to just switch gears since hopefully everyone has a great sense of AC3 and what it does. And then I'll talk specifically about the liver cancer working group. So as I mentioned, I am one of the co-leaders. I'm working at Sylvester Comprehensive Cancer Center, which is part of the University of Miami Miller School of Medicine. And I'm joined by Rukia Kabaya, who's at Aroha Cancer Center in Kenya, and Rashika Banadine, who's at University Hospital of Martinique. The objectives for our group is to really help understand the global epidemiology of liver cancer, understanding that there are a lot of gaps in our knowledge, especially in areas where there may not be standardized approaches to registries. Describe a little bit about our ongoing liver cancer working group projects, and then hopefully discuss opportunities for collaboration. And I see there's a lot in the chat already, so hopefully there's some questions that I'll be able to answer. So this is the group prior to the conference. Actually, as a result of the conference, we had a lot of individuals who were really interested in joining the liver cancer working group. We're one of the newer working groups, so the pathology group is the newest, but I've been a member of AC3 since 2017, so about 7 years. And, you know, even though liver cancer is obviously very important to everyone who's on this call, because it doesn't necessarily affect as many individuals as seen in, for example, breast cancer or prostate cancer, oftentimes there's not a lot of attention focused on it. And so there have been very few of us that were interested in liver cancer. But as a result, like I said, about 9 people indicated interest, and they're going in through the process of vetting, and so that they can become members and then subsequently join our group. But this is Dr. Lynch, Dr. Kabaya, Dr. Buchanan-Part. And again, this group is very representative, many from the Caribbean and many from the United States, and Dr. Kabaya from Kenya. So back to liver cancer. Worldwide, the rates of liver cancer are increasing in many regions of the world. So we know that, and this is why we pay so much attention to it. This is something that I got online. It's a liver cancer fact sheet by the World Health Organization, but it looks like the global epidemiology of liver cancer, because this is really important when we're trying to think about the work that we do, the projects we conceive. We want to make sure that we're targeting areas that have the highest risk. And so you can see here in the slides, we have in both sexes, males and females, number of new cases, as well as cumulative risk. And you can see that the highest cumulative risk is actually in Northern Africa, in both males and females. Western Africa has the next highest, which 0.94. And in males, it's 1.29, and females is less, as is the rate. It's always a male predominant cancer. So if we were to focus our energy, we would think about these regions in terms of projects and partners. In terms of North America, the risk is slightly lower, 0.86, but again, we see a significant difference in males compared to females. And this is sort of more of the same, which just shows you more in a map, the age standardized incidence rates and where these rates are the hottest. So just as I mentioned, you know, the United States is actually not one of the lower areas, it's one of the higher areas. One of the challenges with the Caribbean is that the islands are so small, and generally in maps, they're not well represented. But you can see that there are some areas which they've used these little circles that draw our attention to, where either we have very high rates, and you can see that, or actually conversely, we don't have information at all. And that's a challenge, right? And so similarly, West Africa, Northern Africa, we see high rates of liver cancer. And this is for females, and it's basically the same sort of map. You see similar concerns. So why do we focus on liver cancer? Because it is deadly. And so while liver cancer is the 5th highest cause of new cancer cases, it's the 3rd highest cause of death. So you can see here, it accounts for 4.7% of all new liver cancer cases in 2020, but accounted for 8.3%, so a larger slice of the number of deaths in 2020. And there are 2 types of liver cancer. So we'll just talk very briefly so that I can talk about the fact that in most of these slides that I show, oftentimes they lump these cancers together. And so we have hepatocellular carcinoma, which accounts for 80% of all primary liver cancer cases. 80 to 90% of these cases occur in patients with liver disease, and there are screening recommendations for individuals at increased risk. And we'll compare this to cholangiocarcinoma, intrahepatic cholangiocarcinoma, which accounts for 15% of all liver cancer cases. Most patients with cholangiocarcinoma do not have liver disease, and at present, there are no screening recommendations in the general population. So you just can see the relationship between the hepatocytes, or the liver cells, and the bile ducts, and those cells that develop cancer in cholangiocarcinoma versus HCC, as we often call it. So the risk factors include liver disease, as I mentioned, so alcohol-related liver disease, metabolic associated steatotic liver disease, which was previously known as non-alcoholic fatty liver disease, viral hepatitis, autoimmune types of liver disease, and also genetic liver disease can also contribute to liver cancer. So the mission and vision, the mission of AC3 is to study viral, genetic, environmental, and lifestyle factors for cancer risk and outcomes in populations of African descent. And then the vision is that AC3 will be a broad-based resource for education, training, and research on etiology, screening, prevention, treatment, and survivorship related to cancer in populations of African descent. So I'm just going to now share some of the work that we've been doing. And a lot of this work is actually independent, out in with one collaborative project that we've done. So Dr. Rukia Kabaya, again, she's in Maroha Cancer Center, and I'm not going to share any of her data. I'll just speak about the research that she's done, which includes retrospective analysis of liver cancer patients at 2 centers in Kenya. And 50% of the cases were caused by or associated with hepatitis B. So this is important when we're starting to think about what we all have in common as centers and thinking about collaborative projects. Obviously, hepatitis B is an important focus. Only 5% of the HCC cases were related to hepatitis C. So that's something that's really important. Other than that, things that were notable about her data is that there's a young age and development of liver cancer compared to what you might see if you look at other sources worldwide. Dr. Pinheiro is also a member of AC3. He also is at Sylvester Comprehensive Cancer Center. He's an epidemiologist, and what he's done, this is some recent work that was published, and looks at race and ethnicity in detailed categories. So oftentimes when we think about liver cancer and we think about risk, there's a lot of data about race and ethnicity, but usually racial groups and ethnic groups are lumped together. So you'll just say Black and you'll just say Latino. But when you actually start to disaggregate the groups, you start to notice different trends in terms of the rates of cancer, in terms of survival, in terms of the cause. And so he had a grant from the Florida Department of Health where he broke apart. So if you look in here, it's probably easiest to see if you look focused on Black patients. If you think about whether or not they're West Indian, versus Haitian-born Black individuals versus those born in the United States, you see the rates of cancer. And this is for men. So this is just one example. And this is by female. So again, the point is that no group is a monolith. We've heard that, and that is like something that's commonly stated. Every group is different, but if you look at it, you'll see that there's differences in terms of rates of cancer, and there's also differences in the etiology of cancer. So looking at leading cause of ACC by detailed race, ethnicity, and sex, you can see if you, again, look at the group of Black individuals, looking at males, and we're talking about males born in Haiti, we're more concerned about hepatitis B, whereas those born in the West Indies or the United States were more focused on hepatitis C. And you see a lot of variability when you look at our Latino individuals as well. And so this, again, is just another representation of the same thing, and that you can, when you're thinking about cancer control, you're thinking about diseases that are more likely to lead to chronic liver disease, cirrhosis, and then liver cancer, and the understanding that it is different depending on groups. And that is noted for Black individuals, Hispanic individuals, and Asian individuals as well. So a little bit about some of the work that I've done. So I am a clinician, I'm a hepatologist. I take care of patients who have liver cancer, as well as those with liver disease and cirrhosis. And the first thing I did when I got to the University of Miami is that we did a retrospective analysis of patients who were diagnosed with liver cancer, and we looked to see if there were significant differences in survival. And this has been done in other centers as well. So in this table, the first rows are my data. We had over 900 individuals, and you can see a significant difference in the survival. In our Black patients, only 425 days survival compared to white patients who had 904.5. Similarly, at UT Southwestern, they had notable differences and disparities in survival, and they also did a meta-analysis with lots of patients and found similar things, and that the rate of death is highest in Black patients. One of the other things we found is that, again, along the lines of Dr. Pinedo's work, is that Black patients that are from Haiti had significantly lower survival. So when we disaggregated, our Black patients who were born in Haiti lived only 172 days compared to other Black patients who lived 523 days. So we also looked at data in the state of Florida, trying to understand, and we adjusted for a number of different variables: gender, age, whether people had insurance, what type of surgery, and whether they received treatments. And Black patients had 17% increased risk of death compared to Latino patients. White patients had a 9% increased risk of death. And one of the things that was important is that oftentimes patients, when people think about disparities work, they think about the fact that people don't have access to insurance and they may be poor. And so essentially they dismiss a lot of the findings by saying that, well, that's the problem, that people don't have insurance and that they're poor. But actually we found that neighborhood poverty was actually highest in the areas where Hispanic patients live. But what was notable is that they live closest to transplant and cancer centers. And so that might have influenced their survival. In order to understand why we are having these outcomes, you can only really generate questions when you look backwards. And so our retrospective data, while informative, it is limited because we don't understand why these differences exist. So since 2018, we've actually been following patients over time. We now have over 2,000 patients, and these people have chronic liver disease, cirrhosis, as well as liver cancer. We do surveys to understand quality of life, alcohol use, financial toxicities of treatments, to understand stress levels, how isolated they are, whether they exercise, and their health literacy. And so one of the things that we do is we try to enroll everybody with liver cancer in the study. And we've noted that there's significant disparities in terms of who actually is enrolled in the study. And so we have some subsequent studies looking at how to increase enrollment. And part of that is actually just helping patients with things that are more important to them, like whether or not they have food to eat or whether or not they're going to get fired from their job. And so that's a navigation project that we started recently. And then finally, I'll close with Dr. Sean Patrick Prince's project. He led this project. He's working currently actually as a hospitalist, but will be starting as a GI fellow. He's from the University of West Indies in Jamaica, and then did his residency in University of Miami Holy Cross. And so he, along with our group, we decided to do a literature review and look at the differences in the incidence and survivor of liver cancer in persons of African descent in the United States, Caribbean, and Africa. So he identified over 6,000 records through our database screening. We had to exclude duplicates, of course, so then screen 3,866, 3,868 abstracts, and then a large number of those failed to meet our inclusion and exclusion criteria. Reviewed 223 full text articles, of which many did not meet inclusion and exclusion criteria, and then included 21 articles in our qualitative synthesis. So we're working on finalizing this for publication, but we found that African Americans have the highest rates of HCC and hepatitis C-related HCC. Afro-Caribbean men, and specifically the Haitian population, accounted for many hepatitis B-related HCC cases. Despite elevated rates of age-standardized liver cancer incidence and mortality rates in Northern and Western Africa, African immigrants to the U.S. have lower rates of cancer overall. And then among those living in the U.S., liver cancer mortality was higher in East Africans compared to West Central African. And then Black patients had highest 5-year HCC mortality rate, specifically in those with low socioeconomic status. So we're still in the process of developing new projects, and this is some of the opportunities for collaboration. Some of the things I mentioned. So hepatitis B is really important for me, as I just mentioned, showing my data from Miami. We have a large population of individuals with hepatitis B. We've done a lot of other research in the community, trying to raise awareness, and also trying to see if we can do home-based screening and whether or not it's feasible or acceptable. We've been doing screening in health fairs as well, but this is important actually in all of our regions. So this is one of these hepatitis B related ACC is something that's really important, and it could be screening programs for hepatitis B, screening programs for HCC and those people who have Hep B, and then of course treatment. Aflatoxin is actually something that we know it's a fungal toxin that increases the risk of liver cancer. And it is often found in high amounts in regions where there's also hepatitis B. So at the conference, a lot of our colleagues from Namibia, for example, were really interested in aflatoxin. And I think that this is something that in the United States is taken for granted, that people may have had exposure to aflatoxin at a point in their life, but also that it's ongoing because essentially there are lots of issues with storage of foodstuffs, and there's lots of concerns that are sort of not necessarily their other priorities, I should say. So while we know that how one stores their food might increase or decrease their risk of developing liver cancer, that may not be something that on a governmental level or societal level, a specific region is able to address because there are more pressing issues. But this is something that's really important. So making sure that there is awareness, especially at the local level, not just sort of at the academia level, but making sure that at the local level, people understand the risk. Registry-based projects. So this is something we've been working on, combining information from the various AC3 members countries and the registries of those countries so that we can start to do look at some of this data as well. And then the goal, of course, is to have prospective cohort studies and even look at things like genetics. So we had a lot of conversations, even with some industry partners during the meeting. And I will say that one of the good things about being one of the newer groups is that we get to see the success of the other groups. And there has been tremendous success in the prostate and the women cancers working group. And they've been able to secure really large grants, such as a Chan Zuckerberg grant. And that's been able to build infrastructure in many different regions so that patients are able to be enrolled in prospective cohorts. That helps the patient, that helps the institution, building infrastructure, making sure that we have what we need in terms of freezers, in terms of statistical support, et cetera. And so learning from the experience of our colleagues in the other cancer groups, working groups is really helpful for us because, why reinvent the wheel if they've done things that are very successful? We can adapt. And so that's the goal ultimately as well. So I think my last slide is just for questions. And this is the thing, I know it's a webinar, so we'll try to adjust the questions in the chat, but we're really interested about liver cancer in respective communities in terms of the causes, issues with survival and treatments, and what projects might be interesting for us to work on. And so that's it, and I'll stop sharing, and then maybe we'll have some questions.
Thank you so much, Dr. Jones. This has been a really, really insightful presentation and really extraordinary work that your group is doing. So thank you so much for sharing. Please feel free to audience members to put any questions you may have in the Q&A box or the chat as they arise. I'll start with a couple that came to mind for me. So the navigation project that you're working on in the US, that's so great to address, the deeper needs that a lot of people have that might prevent participation in research. So I'd love to just hear a little more about kind of how that's going, and also if that's been replicated in any other settings, because I know, research participation, particularly in Africa, it can be really challenging as well. So any thoughts you have on that would be great to hear.
Sure. So we are actually just in the process. This grant is a 2-year grant. And so the first thing that we did is we did some interviews one-on-one with various stakeholders, including patients, caregivers, physicians, advanced practice providers, research coordinators, pretty much everyone you can think of, social workers, nurse navigators, to try to understand what they saw as the needs of this specific patient population. And then we assembled all of that information and then created an intervention, which is this navigation program, which at its base relies on social work screening. And also we have one lay navigator, because I think people are familiar with the concept of like nurse navigation, but it actually differs. I mean, that is a nurse who helps to navigate patients, but it looks different at every center. For some patients, that's just like helping them to get the first appointment. And for some, it's someone they can call all the time. And we're trying to actually replicate the latter so that we can address social issues or concerns that might interfere with someone's ability to hear about their treatment or to attend visits for their treatment. So we just started really the month of April to start navigating. So we have one individual, and I'm really excited that we were able to hire someone who is Haitian, and so she also speaks Creole and English. And then we have another coordinator who speaks Spanish and English. And so we're able to navigate all of our patients and speak to them in their preferred language. So that again, similar to what I mentioned with AC3, is building the relationship. I think when people think about the fact that we don't have a lot of representation in clinical trials and clinical research, and a lot of times people just say, well, there's mistrust, right? But we don't focus on the reasons that there is mistrust, and that honestly, many of those reasons are valid. And not all of us are empathetic enough to think about what might interfere with someone's desire to or ability to get treatment. And so we notice you're not, when people would decline to participate in our cohort, we would never say, why not? But they would offer like, oh, I'm just so overwhelmed. And, I just can't, I have work, even though what we do is in the context of clinical care. So it's not really burdensome, but, people offer reasons. And so we started to think about, okay, and we know from our own clinical experience that, there are people that will delay treatment because they're afraid to lose their job. And if they lose their job, they lose their insurance. So there's lots of good reasons that people are struggling. And so we can start to do something to try to alleviate it. So our goal is to at least navigate 50 people and then analyze the results. Because unfortunately, part of it is not just like, does it help the patient? That's important. But the other part of it is, again, your question of adapting it into other environments and scaling it up. So in order to do that, we have to know a little bit more. We need to know how many people are going to be required. How much, like, what does that even mean to navigate? How many minutes are spent with each individual? How many contacts per week? So we're studying it so that when we say, hey, this was, I can't imagine it's not going to be helpful. So when we say, hey, this is helpful, we know what we need to scale it up. So that if we're offering it, we're not sort of doing a smaller version of what we know is the best practice. So that's where we are. We're still in the early stage. I'm really excited though, because for another talk I'm giving later this week, I was actually starting to look at some of the interventions that we've tried in the space of liver cancer. And really most of them are very low cost, like mailing a letter or having someone make a phone call. And I think part of that is just because there hasn't been much focus and certainly not dedicated funding. So hopefully we can start to step it up, because mailing someone a letter isn't very effective. But I think those investigators that did it, well, that was what they could do at that moment in time, right? That's what was affordable. But if we're really serious about improving care and improving outcomes, we have to put our money where our mouth is.
Yeah, 100%. Well, yeah, thank you so much for sharing about that. I think that's a really exciting initiative, and is, yeah, great to kind of place health in a broader sort of context of people's lives. So, so that's very cool. Something else I was just kind of curious that you mentioned in your data was just about how particularly African immigrants in the US actually have lower rates of cancer overall. And then East Africans tend to have higher rates than West Africans. I was just curious if there was any kind of further insights into that. Is that because of kind of increased hepatitis B screening perhaps earlier on?
I think that's likely the case, is that increased screening. And I think people tend to maybe live in enclaves. And so I think when we're thinking about East African, that's probably driven mainly by, we have certain regions in the Midwest, like Somalia, in Minnesota, for example. And so I think it's probably access to care, honestly. And then I don't know that that's surprising, because when you think about immigrants in the United States compared to people in the home country, for example, and it's the same as seen for Latinos, oftentimes they may be healthier, because healthy people can immigrate, healthy people can travel.
Yeah.
And then the access, all of the barriers really to being able to work in the United States. So oftentimes may have more resources. And so the ability to get recognized to have hepatitis B is very different than worldwide. So when that data was thinking about like rates that are reported worldwide. So it is better. I mean, one thing I will say I take away from my time at the AC3 meeting in October was actually a gratitude that, you know, there's lots that we are frustrated about with the health system in the United States. It really is broken. I think most honest people will say that. People shouldn't have to like skip meals or worry about losing work. But this is the reality that we live in. And so I'm very frustrated like every day when there's a patient that like I want to help and there's something that's preventing me from helping someone. And it's an insurance thing or something that's just silly. But then just really talking with my colleagues about insurance and how that works and how people get treatment and what do people have to do to get treatment, and realizing like how different it is. And so it did inspire a little gratitude for where we are. But I mean, I think the wish is that everyone advances so that we have more of a global approach to understanding who has hepatitis B, to making sure that treatments are affordable everywhere for patients who need treatment. So that's the advocacy part that I know the Hepatitis B Foundation has done an excellent job of, because that to me is the next step. This is really hepatitis B related HCC is preventable. It really is. And if we recognize patients who have it and treat them appropriately and monitor all of them, if we have the bandwidth to do that, and really the technology necessary to do that is not that difficult. Ultrasound, for example, is something that really could be scaled up. And then certainly development of blood-based tests for liver cancer risk screening is something that people are working on furiously, and hopefully that'll help as well, because that's really important. But yeah, it's preventable. So it's really sad when we have a 40-year-old or a 20-year-old with liver cancer and they didn't know that they had hepatitis and they should have been tested. I've had patients who even a family member had it and they still didn't know, and so they weren't tested. And so this is sort of, I think, the goal of all of ours. So
yeah, no, 100%. And hopefully the WHO new guidelines surrounding treatment for hepatitis B, implementation is another matter, but the fact that those now exist and have been updated will hopefully be helpful in increasing that globally. The last kind of question, also, if any, feel free to put any questions that you may have in the chat. And if anyone is interested in collaboration opportunities, like Dr. Jones mentioned as well, is it okay if we share your email address with?
Absolutely, that'd be great.
Yeah. Okay, that would be wonderful. So if anyone, this is a really great consortium to be a part of and to kind of join the work with. So I just have one more other question, and then we'll ask one more thing about the consortium itself. But so in terms of liver cancer screening and early detection being accessible to to more people globally, is there especially for people who are living such as in Africa, away from academic centers or urban, like an urban setting where such testing might be more accessible. Just curious if there's any kind of efforts to work on, for example, training of more community health workers in more rural settings, and just efforts to reach a broader expanse of people who may be less aware about hepatitis B or aflatoxin or other etiologies of liver cancer.
Yeah, I think that's going to be really important, is the incorporation of other, I don't want to say extenders, because I don't think that's the right word to use. I think if we think about the way that healthcare used to be delivered, it was way more community-based. People in the community delivered care to people in the community. And so community health workers, I think, play a critical role in adjusting the amount of time that they're able to spend. So certainly educational opportunities and what's not available in the United States, but hopefully will become available, is really easy point of care testing, because I think that that goes hand in hand. So, you know, a community health worker, in our study, they did draw blood and they took it to the Center for Haitian Studies and they centrifused it and they brought it back to lab. That's a lot. Like, that's not typical, right?
Yeah.
So to have a point of care test that you can get answers right away and then link people to appropriate care. And much of the care can be done remotely. So that's the other thing is, you know, in rural areas and in those areas with geographic disparities, is using what we have. And so that requires a lot of advocacy too, because there aren't enough healthcare providers really. And certainly those that may feel comfortable with certain conditions like hepatitis B is confusing to a lot of people. But we have the internet, really. We have the ability to teach. We have, like, webinars like this are great. We have the ability to see patients remotely. We have the ability to offer that to other countries as well. And so I think that that is huge because, I mean, we even have the ability to share images if there's a question about masses. I mean, there's a lot that we're not doing that we could be doing in order to revolutionize the care that's delivered. And so that everyone is reached no matter where they live. You don't have to live next to the cancer center to have the best outcome. That's the situation we're in now. You live close, you're going to make it to your appointments, you're going to get seen sooner, that sort of thing. And so I think that incorporating community health workers, I think this is a space in hepatitis B that I'd love to see grow, and not just like in these pockets where we know we have large populations, but sort of throughout, developing maybe even regional networks, because I think it would be really important.
Yeah, 100%. Yeah, and really leveraging the, you know, like you said, the power of virtual education and being able to reach more people and provider education as well is so crucial. So I see David Iranam has a question. So let's see. We are a team of 28 health personnel working in Cross River, Nigeria. So we are glad to serve a patient community-based organization for partnership, collaboration, as well as sponsorship. Are there future opportunities, or will there be future opportunities for such programs? So yeah, so maybe just speaking a little bit more about the consortium and some types of ways for folks to get involved.
Yeah, so the way that it works with the consortium, and actually right now, the process of approving new members is it's being reestablished. And the reason is because I spent a lot of time talking about how we do things and how they're different. And I think that as a consortium, we're really very protective of members and their ideas, and actually being responsive to the fact that a better resourced member could take the idea of a lesser resource member and run with it, right? That happens all the time. Getting scooped. It happens all the time. And those with more resources are able to do it. So we're really careful on the front end, making sure that people understand how collaboratively and cooperatively we work, so that that doesn't happen. Because it has happened. And so the way that it works is that there's an application and then there's a one-on-one meeting. And I think what they're trying to do is streamline it, just because with the success of the network, of course, more and more individuals want to collaborate. And I think everybody wants that. I mean, the more people involved, the more we can accomplish. And so it's just a matter of making sure that we can actually meet and approve members in a timely manner. So in the short term, anybody can email me and I can connect them to how they would apply. But again, I do know that we're in the process of revamping it. But yes, the idea is that we're working, and then definitely you can see from my slides that we need more people in Africa. We only have really a contingent from Kenya. We had one individual from Ethiopia, but they're not as active as when we first started. So we'd love to have more involvement so that we can start to work with each other and think about ideas for projects or what have you.
Fantastic. Yeah, I think that there are folks on the call from various places within Africa. So please, I just put Dr. Jones's email in the chat, and we'll also share it in the follow-up material. So please feel free to reach out and get involved. It's always great to, you know, to have more representation and more folks involved in this really crucial issue. So thank you so much. This has been so insightful and just really inspiring to hear about all the tremendous work that you're doing. So thank you very much for sharing with us. And I think, Quinn, do you mind just sharing the last slide of the presentation? So thank you so much again to Dr. Jones and to everyone for joining today. We really appreciate you being here, and we hope that you found this presentation informative and valuable to your work or life, and that you can apply it in some way moving forward. Again, we really encourage you to reach out to learn more and get involved. A recording of this webinar will be emailed out to all attendees, and we encourage you to visit our website and to learn more about our overall organization, the Hepatitis B Foundation, as well as our coalition, which is CHIPO. And I can put the website for CHIPO in the chat. And we'll also share that with the notes as well. If you're interested in joining CHIPO or learning more, you can feel free to reach out to me directly. My email address is on the slide. And then there is the address, the website for CHIPO. Oh, I see we have one more question that came in the chat. Yes, David, Dr. Jones's email is in the chat, and I'll also send it out after the presentation as well. So thank you so much for asking. And we encourage everyone as well, if you can check out CHIPO online, email me, and also feel free to follow us on social media. We are at CHIPO HBV on Facebook, Instagram, and Twitter. So thank you so much again to everyone for joining, and to Dr. Jones for this great presentation. And we'll definitely follow up via email. So thank you so much, and have a wonderful rest of the day, everybody.
Thank you.
Okay, take care.